The Uganda we want. So mu Uganda gye twagala mu lutalo luno olw'okulwanyisa obulabbayo obukenuzi nze kyempita obuvundu. Munna Uganda alina okuba nga yeenyigiramu.
Ffenna twenyigire mu lutalo.
Ate abalala tebasomye kuzimba wabula bayize okuzimba.
Uganda gye twagala okulaba ng'enguudo zonna nkole nungi, public transport nga weeri.
Kati eno gavumenti eriwo erina akabonero ka Lucifer. Buli kyotunulako mu Uganda kiriko oxygen. Either babika amawulire malungi oba mawulire mabi. Minisita teyeetaagisa kabangali budde buno zaaki.
At this time, why should somebody import furniture from outside Uganda? Let us leave NRM to be in charge for another 36 years or more.
I really want to see a Uganda that believes in the rule of law. If you have a constitution in place, follow it to the letter. Don't change laws just because you want them to favor you.
Kuba njagala omanye nti obugagga bwonna Uganda bwe yeeyagaliramu buyita waffe ku ttaka lyaffe. Naye busoga mugidibaze.
How can a referral hospital refer you to a private clinic? The Uganda we want buli muntu ateekwa okumanya nti I am a stakeholder, nkwatibwako si kwesuulirayo gwa naggamba.
Uganda oyinza okukakana nga mwe mulina bagraduates aba university nga bangi okusinga ebungereza. Mwe mufokasinga nnyo ku degree. Eri bo bafokasinga nnyo nti byensomye mbijjeemu omulimu n'enkola.
We are dreaming of a Uganda where at a young age there is such a relationship between parent and son, parent and daughter, where the daughter can say this is what I want.
Uganda gye twagala empya tesobola kubeerawo nga tewali mateeka. Amateeka agakola.
The Uganda we want. Welcome to the Uganda we want. This is our second episode with Dr. Daniel Byabakama. He's the head of HIV prevention at the Uganda AIDS Commission. In the first episode, he shared with us some of the functions, and he aired out what they are working on, especially those of you who have been having fears that probably if now our funding for people who are being helped by the donation from the US who are infected with HIV, now I think their life is gone. Doctor confirmed it to us, and we heard it from the horse's mouth that no, they have a sustainability roadmap where they hope and they think that the government of Uganda will listen to them and be able to work with them to make sure that our Ugandan fear is taken away. So, Doctor, before I pose the question, could you first greet our viewers and our listeners in this second episode, and then we'll pick it up from there.
So good evening, our listeners.
Well, Doctor, is it possible, according to you, you've been in this thing for many years, is it possible to achieve a Uganda free from HIV or AIDS? And if it is a yes from you, how and why are we still talking about this? What are you preventing? What have you been preventing that is not, going away?
Thank you.
Yeah.
We have a plan. In June 2017, our President, His Excellency General Kaguta Museveni, launched a plan which he hatched by himself, called the Presidential Fast Track Initiative on Ending AIDS as a Public Health Threat by 2030. So in that plan, it was an evidence-based plan. The President had a conversation with the technical leaders and asked questions. And we convinced him that we can end AIDS as a public health threat by 2030. And he launched his plan. And now, I want to answer your question. Yes, it is possible to end AIDS as a public health threat. So what that means is that it is possible that there is no any more people dying from AIDS-related diseases. AIDS-related illness. Last year, we had a high number, 20,000. And for like the last 5 years, we have stagnated around there. But why did the 20,000 die? I would say most of them is because they did not come in time, or they did not come at all to receive our free, highly effective HIV treatment, which is so available, even at Health Center 3. We may explore what could be the contributing factor for why people still don't come for free life-saving medication. If we could address those issues, that is the but. It is possible, but we still have challenges that we must deal with to make sure the 20,000 people who died last year, who shouldn't have died, so what stood in their way, we must remove it. Together, me and you and everybody listening. Last year, we had 38,000 new HIV infections. So as part of ending AIDS as a public health threat, it means there's no more HIV transmission. Nobody is contracting HIV. Of the 38,000 who contracted HIV, 4,700 are children born to HIV-positive mothers. We have a whole program to make sure there's no child born with HIV. Evidence-based. A simple, straightforward program. Simple steps. But 4,700 contracted HIV last year. What stood in the way of pregnant mothers and their exposed babies from accessing the program we have put in place for them, free, accessible at the nearest health facility, but still mothers do not come? It is possible to end mother-to-child, babies born with HIV, but we must first do something, me and you and all the husbands outside there, to make sure that the mothers who are HIV positive are accessing the evidence-based scientific tools we have to help them deliver healthy babies. Last year, out of the 38,000 new HIV infections we got, 22,000 were women above the age of 15, and 11,000 were men. So you can see that the HIV epidemic still affects women disproportionately. The number of women who contracted HIV were twice the amount of men who contracted HIV. Partly because we don't have enough tools for HIV prevention that are under the control of the woman. The woman is still at the mercy of the man. Most of the easily available tools, is it a condom? A woman still needs the cooperation of the man. Even the newer tools, we have like pre-exposure prophylaxis. The woman still needs the cooperation of her husband. But now, if a man has been, let me say, careless, has made mistakes, the incentive for such a man to prioritize protection and prevention is so low. He may not bother to use a condom. That puts the woman at risk. But partly, the woman is at risk because of gender inequality. There are so many women who are in marital relationships, but they are at the mercy of the man. The man does what he wants. If he came with gonorrhea today, you have no say. If they told you he has fathered children in the villages, you have no say. You are at his mercy. And such is the arrangement for most women, that they don't have the power to caution the man and say, my friend, you're living recklessly, I want you to stop.
The man is the head.
The man is the head. He has the right to do whatever he wants to do, and the woman stays helpless. So it looks like for us to end AIDS as a public health threat, to end the disproportionate number of new HIV infections among women, we have some work to do, me and you and everybody listening, to end gender-based inequality, gender-based virus, the society norms that promote the recklessness of a man, and the subordinate status of a woman, those we need to rethink them right now if we are committed to ending AIDS.
How about the religious norms?
Yes, religious and cultural norms.
Religious and cultural norms.
That is why the HIV response is a multi-sectoral response. That is the very reason why the HIV response is not purely a medical response. It's not a health sector response. Because we are aware, sort of some of these challenges that put women and men, that propagate vulnerability, we need the cultural leader to do their part, to call upon their people to revise some of these retrogressive cultural practices. We need the religious leader to motivate their following and maybe to tone down on some of the practices they preach that are continue to put our people at risk, like that gender imbalance, the subordinate nature of women, that a woman whose husband has contracted gonorrhea, she has no right to question. She has no right to demand protection. So we need to address some of those things. If we don't address those, then the end is going to be complicated. But the good thing is there is commitment and we have the tools. The tools to help us end new HIV infections. In addition to our traditional abstinence, be faithful, and condom, we have invented new tools, highly effective tools. Abstinence still works. For us as a national HIV...
Is that to these young people, or because when that's a message that probably people view as is supposed to be for young people? Abstinence, young people.
It is.
In schools.
But abstinence and being faithful, to me, they go together.
Yeah.
So I can give you an example. If you went to study right now, that you got a scholarship and you've gone to Denmark to study, 2 years, would you expect your spouse you left behind to abstain? She will abstain.
Yeah.
Every day, people are abstaining, even if it's for a brief time. If you go for an assignment that requires you to stay in the field for 3 weeks, you may say you're being faithful, but to me, you are abstaining.
You're abstaining. Yeah.
You're abstaining. So the role of abstinence, yes, abstinence is being promoted mainly for the young and married people. But I would want to convince you that there are so many adults, grown men and women, who abstain for a certain period of time because their spouse is away for work in Kenya for business. They stayed home, they have abstained. They may say they are being faithful, but they are abstaining. So to me, the contribution of abstinence to ending or to minimizing HIV transmission is being underreported. So many people are making an effort to let temptation go away, to not indulge in casual sex, to abstain for the sake of their health. So abstinence still works, and we would want to see more abstinence. Why do I want to say that? When we analyze our data, we notice that the second highest contributor of new HIV infections in this country are formerly married men. They contribute 20% of new HIV infections. As a single group, divorced men who have run away from their wives.
Doctor, first pause a bit. Married men.
Formerly married.
Formerly married.
Yes. So I am divorced.
How did they get? Okay.
Separated.
Divorced or separated.
Separated. So they contribute the second highest number of HIV infection in this country. How I would wish, after making a decision to abandon your wife, you would abstain.
Or the wife abandoning you.
It's either way.
It could be either way.
The third contributor of new HIV infections in the country are actually formerly married women, women who have divorced from their husbands or separated. They contribute the third highest. So you see people jumping around threatening to divorce, but they are not divorcing to a better place. And I know most of them are divorcing because of infidelity or something, or suspicion. But when they divorce, they start meeting their needs in a casual way. And
in a reckless way.
Yeah. So the consequence is the highest number of new HIV infections are occurring among men who have just abandoned their wives through divorce or separation. The third highest number of new HIV infections are occurring among women who have just abandoned their spouses, their husbands, divorced or separated. More than sex workers. Sex workers come in a distant fourth. So if they would, after making a decision to separate, I would imagine you are prepared to abstain. You would abstain. If they would try even to minimize.
In other words, what you're preaching to us is, sorry to say preaching, because so much for the religious people, but you're preaching something here. Before you divorce with your wife or with your spouse,
absolutely,
you have to convince yourself
that
you're ready to abstain.
Yes, of course.
If you're not ready to abstain,
you better
stay with
in
her
marriage.
or
Yes,
with
of
him.
course. Yes. Because we see when they jump out,
point noted.
They jump out of the saucepan and they end up in the fire.
In the fire, yes.
So if you are ready to divorce, and now the habit of divorce separation is so high, around 19% of all adults have divorced. So we would want to encourage them, let them plan to abstain, like they did when they are young, when they are not yet married, until they get another spouse. Otherwise, we see the casual way of meeting their needs contribute significantly to the number of new HIV infections. You should also ask me who is leading number one in the number of new HIV infections. We see that across the country, young women between the age of 15 and 29.
Yeah, we were covering the story when you came as a commission, you know, when you are giving a report, the fact sheet, and I was like, what is this? 15 years?
Yes, of course. Yes, of course. Yes, of course. So between 15 and the age of 29, we see that as the highest risk age group and the population. Girls between the age of 15 and 29, those are the girls who are looking for spouses. Some of them are genuinely looking for a spouse, a future partner. But they forget to use protection. Some of them, because of our cultural upbringing, a woman who is growing up is not empowered to negotiate with a man, even if she's older, the man is older, at an equal footing. This is my body. So they become unnecessarily submissive to a grown-up man. Not because they want, but because they get overwhelmed. They fear. You're supposed to fear a grown-up man. So we see a significant number of young women contracting HIV. Out of number one, sexual exploitation by older men, because they are trained by culture to be submissive. They break down. They can't negotiate family with men and say no. But also see poverty. There are so many young women within the city who have migrated from the villages, from their secure rural homes, to take up jobs that pay little money, 150,000 per month, including rent and food
and transport,
and clothing and transport. Such women are prone to end up to submit to the temptation of transactional sex. So there are elements of poverty and the urban migration for better jobs, which are poor paying jobs, but also there are cultural issues where a woman is raised to be less powerful when faced with a man. And there are also elements of violence. So we would want to see us working with the young women. Fortunately, in our new strategy, we have HIV prevention tools. The newer tools, beyond abstinence, beyond being faithful, beyond condom, which are under the control of the woman. Most of these tools were being supported by the donor. So I am sure there are government leaders, members of parliament who would be listening, would want to see leaders come in and fill the gap, because a cross-section of our population, it's not that they are promiscuous. It's not that they are prostitutes that they would want to call them. They are badly behaved. No. It is that circumstances connive to disempower a certain section of the population. You imagine a house girl staying in a man's home, an abusive man's home. It's not that she's badly behaved. It's that she finds herself in a situation where she's powerless. If such a house girl who has seen that her boss can be abusive runs to a health facility and says, give me pre-exposure prophylaxis. This is one of the tools we have for the helpless population. The people whose circumstances disempower them. They're not able to abstain. They are not able to be faithful to anybody. They are not able to negotiate a condom. They are a very significant population. So we would want to see our stakeholders, the government, our leaders, accept to locate money. The conversations we have had in the past from various policymakers is that supporting such initiatives, it is equivalent to promoting promiscuity. But I would want to argue that it is not true. There are so many, especially young women, whose circumstances beyond their control. They end up in a highly vulnerable situation and they're helpless about it. So as a government, because eventually in the end, when they contract HIV, the bill for their treatment comes to government. It is better to invest in their prevention. So such tools, number one, we have been having what we call the vaginal ring. Purely supported by the US government, but the support looks like it will be stopped. The second one is pre-exposure prophylaxis, oral pre-exposure prophylaxis, where young women, even men, there are so many men who live a highly risky life. They are careless. It's as if they are not aware that there is HIV. Or they are helpless about their sexual needs. Even those they need help, because they are also our brothers and our children. So we would want to make sure those get support. So my estimation is, in this country, we have an estimation of people who get food, a livelihood from selling sex. We call them sex workers. They are helpless. They have no other source of livelihood. If they don't sell sex, their children at home will have no food. They have a most immediate need to feed their children. Around 150,000 people. Each of those in a day has an average of 4 customers. So we can estimate that on the other side, they have like 900,000 customers. So we're looking at a population of like 1 million people who need these newer tools. The newer tools where our policymakers are reluctant to support, because to them it is equivalent to promoting promiscuity, giving people pre-exposure. Pre-exposure means I am giving you prevention before you are exposed to risk. I'm giving you treatment before you are exposed to risk, because I know you're going to be exposed to the risk. And there is nothing I can do to help you not get exposed to the risk. So we had 3 main tools for pre-exposure. The first one was the oral daily pill, supported purely by the US government. We would want the government of Uganda to take it up. Take it up by financing it, but also by our leaders talking about it in a positive light.
Not in a negative way.
Not in a negative way.
Yeah.
Religious leaders, political leaders have often been castigating it, portraying it as promoting promiscuity. We have the injection. We had started giving an injection we call long-acting cabotegravir. 2 monthly injections. You get an injection every 2 months, and you will not contract HIV. Whether you're raped by your boss, whether you're raped because you are a sex worker and your client has refused to wear a condom. So that was purely supported by the US government. But also, that was a subject of minimization by our key policy makers, the religious leaders and the politicians. So we want them to come to the forefront and promote the use of these tools. Because if we don't promote prevention, the number of people contracting HIV every year will keep on increasing. The bill for putting them on life treatment is enormous, it's significant. So we need to go back to drumming prevention and to drum prevention as we did in the 90s. The religious leaders, the political leaders were at the forefront. They have left the campaign of prevention, changing people's attitudes and behaviors to the technical people. The technical people don't convince very many, and they don't have the capacity to reach many. The number of people religious leaders reach on Sunday, one Sunday, if all religious leaders were going to get back to how they used to perform in the 90s, then would be guaranteed that our dream of ending AIDS as a public health threat by 2030.
Doctor, why do you think the political leaders and the religious leaders, for example, are not so much sucked into this campaign? What changed?
Yes, I think several things changed. The first one is information. The information kept on getting advanced, and the knowledge of people in their audience also increased. So in your audience, there are so many people now who know so much about HIV that a religious leader is scared of starting to talk about a topic that is not their expertise. But we are doing something as the Uganda AIDS Commission. We have developed a capacity building plan for key leaders. A religious leader is a very powerful person. They have a large following. People believe in what they say. People take it in. It's like it is sieved. So we would want them to get back to the forefront of the fight against HIV. Number two, we started HIV treatment. The urgency, the immediate pain of seeing your congregation, some members in your congregation wasting away is no longer there. So it's no longer an immediate problem in their eyes. So, but a few leaders who can read the HIV AIDS literature and understand it are doing a good work, but they are not doing as the leaders of the 1990s. If we are to end AIDS as a public health threat by 2030, we would want leaders, especially religious leaders, to get back to the forefront. They have power, they have a following, they have an audience, more than us, the technical leaders.
And the political leaders.
And the political leaders.
Politics is taking us, but
absolutely.
Everything is politics.
Yes. So we would want the leaders to come to the forefront, mobilize the whole country. Because right now, I have told you that the president in June 2017 launched a campaign, the presidential fast track to end AIDS as a public health threat by 2030. If you went to the grassroots, to the villages in Kaberamaido, and you asked them, are you aware there is a President Museveni, there is a president's campaign to end AIDS as a public health threat in this country? I will tell you the people in Kaberamaido may not know. That is because...
But they have a representative.
They have
representatives. Actually.
Absolutely. That's because the messengers of the president's message have also gone silent. So we would want to challenge the leaders, from the members of parliament to ministers to leaders of local governments, to get back to mobilizing the population, to know that we are running a campaign to save this country from the AIDS epidemic. If the people are not mobilized, because once people are mobilized, then everybody is told what they need to do. What are you going to contribute? If you're a person living with HIV, your contribution is to make sure you come for HIV treatment, you take the medication as the doctor has prescribed. That has two advantages: that you will stay healthy, you'll not make orphans. But we have discovered that when people are taking their treatment well, they do not transmit HIV. That means you will no longer transmit HIV to anybody. Now, for the HIV negative person, that means you will not shame anybody who already has HIV. We have discovered that most of the people, I already told you that 20,000 died of AIDS last year. Many of them, they were scared of the shame they would face after being seen in a line picking up HIV treatment. So if we stop stigma, if we stop shaming people living with HIV, that they are free to walk into the clinic and pick their medication, they are free to come for HIV testing and test and know their status, then would have done a good part. So, as an HIV negative person, the first part you have to play is to make sure you kill completely the culture of shaming people. You think, oh, you don't have HIV. It has consequences that they will not take their medication very well and they will continue transmitting HIV in the community.
Wow. Doctor, I wanted to ask you if you have any other Uganda you want to see, but our time is up. In just a minute, summarize for us the kind of Uganda you want to see in line with preventing HIV.
Thank you. So in summary, the Uganda I want to see. Number one, I want to see a Uganda where there is no shaming of people living with HIV. That costs the country enormously. It costs the country in that it is stopping people from coming for treatment that would help them live long and stop transmitting HIV. The Uganda I would want to see is a Uganda where there is no more HIV transmission. It is possible by embracing the tools we have in place. Starting from abstinence, being faithful to your partners, it is still applicable to be faithful to your partners. If you fail, to use a condom, but also to embrace the newer tools we have, including circumcision. I would want to emphasize circumcision. We have discovered that of all the men who contracted HIV last year, more than 80% were the uncircumcised man. So I would want to encourage all men, for reasons of prevention, to go and get circumcised, because most men are going to make a mistake. And it's better you are armed with something. That circumcision gives you protection up to 60%, and that 60% is very significant. So you need to be armed because you don't know when you're going to make a mistake, if you ever make it. And most people will make that mistake. I would want to see Uganda where our brothers and sisters are not dying of AIDS-related illness. There is free, effective medication, easy to take. But we stand in their way. As families, I want to see Uganda where family members support their brothers and sisters who are unfortunate to be already living with HIV to take their medication without shame, without fear, without difficulty. And I think together we shall end the AIDS epidemic by 2030.
Wow, together we shall end HIV epidemic by 2030. We sign out. Thank you so much, Doctor, for your time. Bye-bye. The Uganda we want. So mu Uganda gye twagala mu lutalo luno olw'okulwanyisa obulabbayo obukenuzi nze kyempita obuvundu. Munna Uganda alina okuba nga yeenyigiramu.
Ffenna twenyigire mu lutalo.
Ate abalala tebasomye kuzimba wabula bayize okuzimba.
Uganda gye twagala okulaba ng'enguudo zonna nkole nungi, public transport nga weeri.
Kati eno gavumenti eriwo erina akabonero ka Lucifer. Buli kyotunulako mu Uganda kiriko oxygen. Either babika amawulire malungi oba mawulire mabi. Minisita teyeetaagisa kabangali budde buno. Zaki?
At this time, why should somebody import furniture from outside Uganda? Let us leave NRM to be in charge for another 36 years or more.
I really want to see a Uganda that believes in the rule of law. If you have a constitution in place, follow it to the letter. Don't change laws just because you want them to favor you.
Kuba njagala omanye nti obugagga bwonna Uganda bwe yeeyagaliramu buyita waffe ku ttaka lyaffe. Naye Busoga mugidibaze.
How can a referral hospital refer you to a private clinic? The Uganda we want buli muntu ateekwa okumanya nti I am a stakeholder, nkwatibwako si kwesuulirayo gwa naggamba.
Uganda oyinza okukakana nga mwe muyina bagraduates aba university nga bangi okusinga e Bungereza. Mwe mufokasinga nnyo ku degree. Eri bo bafokasinga nnyo nti byensomye mbijeemu omulimu n'enkola.
We are dreaming of a Uganda where at a young age there is such a relationship between parent and son, parent and daughter, where the daughter can say, this is what I want.
Uganda gye twagala empya tesobola kubeerawo nga tewali mateeka. Amateeka agakola.
The Uganda we want,